cancer, something like that. So typically it's just our breastfeeding moms, our bottle feeding moms don't get mastitis. And that makes sense, right? Because they don't have the cracks and the bleeding at the nipples, and which is a port of bacteria getting in. So that's that. Your book did have ice to treat it after they nursed, and I think that's for the pain and the swelling. But everything else I saw, also that I researched, said heat. You don't want to ice it because you want that milk to flow out to get rid of the bacteria, right? And it doesn't hurt the baby because the baby's got, gastric acid in their stomach, which kills any bacteria that they get. I know it sounds pretty gross, but that's the thinking with the mom still continuing to breastfeed, okay, with mastitis. You just want to move that milk through to get rid of that bacteria. And sometimes the babies get a little bit of diarrhea because of the antibiotics, like we all do. Sometimes we get diarrhea when we're on antibiotics, so they might see that. But the best thing is to keep that milk moving through, so warm is best. Okay? And I mentioned about the cord, that they send the cord away on our moms that we suspect are using drugs to test the cord, and it shows whether the mom has been doing drugs through the pregnancy. It looks back up to 20 weeks, which is pretty impressive. And they do a 13 drug panel, and they can also test for alcohol use during pregnancy with that. So that's pretty cool. Negatives usually come back in a day. Angelique was asking me how quickly we had a mom that there was a situation at DSS that's not accepting her because when she came in, she had been in jail for 2 weeks, so her drug screen was negative. And so, but she was accused of trying to sell her baby in jail. So, not a real great prospect for mom. Being a good mother. So anyway, the nurses was like having a real hard time with that. But they wouldn't take her since her drug screen was negative on admission. So that was kind of crazy. So anyway, for a negative drug screen to come back on those cords, my reading told me that it's a day. For a positive, it takes more 2 to 3 days. So it's pretty quick. So hopefully we can get those results on those cords before mom goes home. So, with us being 1 day last week, I don't know how that turned out, but I'm hopefully going to find out this week how that turned out. Let's see what else. Okay. Rosa picked up on something that had changed from last year's edition of your maternal child book. I had told you that we are to tell the moms not to get pregnant once they get the rubella vaccine for 3 months. Your book has 4 weeks, and that has changed from the edition before this, and I did not catch that. So thank you, Rose. So any questions about what we tell the mom? We'll go with what your book has, 4 weeks. Okay, not to get pregnant for 4 weeks. Okay. And I wanted to make sure that I had told you this. What do we tell our moms about bleeding? What is too much bleeding as far as their pad? More than 1 pad in an hour. I told you that. I was like, don't tell them that. I want to make sure. All right, great. Okay. So, what questions do you guys have for me? I know Rosa has some. Rosa, they might also be others that have questions. Was there anything in particular you just want to look at my notes? Okay. Does anyone have any particular questions? Okay. I'm sorry? 1 pad per hour? No. don't want them to have more than 1 pad an hour. So less than 1 pad an hour is okay. If it's right at an hour, we're watching them pretty closely. But that's kind of, if you're saturating a pad in an hour, that's too much. And that's usually okay. Yes.
Okay, so in my notes, I have that hydrocephaly is like a larger head. A proportion is larger. Is there anything else we need to know about that? Because I
think that's what your exemplars that we talk about. So
okay,
just to know that's what can be the problem. If you see bulging at the mouth, right, a larger head, they can indicate that. Any other questions? Okay, I am sending around the attendance sheet, so you will initial that, and then we'll just keep going. I'm still trying to learn, you guys, but I'll get there eventually. Okay, all right. So we left off. We're going to start here at the APGAR score. So this is the score they do on the babies when the babies are born at 1 minute and 5 minutes. 5 minutes, and it tells us the baby's transition to be born. And what we look for is the heart rate greater, so it's like a scoring system to make it a 10. Heart rate greater than 100 is 2. So the most important thing you're going to see the nurses do is listen to the heart rate. Did you notice that? Or did you not notice that? So that's the most important indicator that this baby is doing good. Because respiratory effort, if we have a baby that is crying, that's a very good sign, and that usually tells us a lot about what their effort are. So the respiratory effort, you can't breathe if you're not crying. So vigorous cry, no respiratory effort would be they're not. We don't want a quiet baby. We want a noisy, crying baby. So if there's no respiratory effort, that would be apnea, and they give 0 for that. A vigorous cry tells us that's good respiratory effort. And a slow cry, they get a 1. They're just kind of, not really vigorously lusty crying. Muscle tone, we want them to be flexed. If their arms and their legs should be flexed, that would be a 2. Some flexion would be a 1, and just a floppy baby, we don't like to see that either, is a 0. Reflex irritability is also kind of like the cry. If they just don't have any reflex at all to that, none, this is a little, or a vigorous cry also tells us that's good reflex irritability.
So we're like checking their reflexes during that step?
No, that's just, it's kind of like, yeah, you're going to see them startling and stuff. We don't really, who asked you that? Oh, I'm sorry. We don't really check the reflexes, but the startle reflex is when, loud noises and bright lights, and so you're going to see that reflex. But if the baby's just laying there floppy, that's a bad sign. But these kind of are a lot alike, muscle tone and reflex. So like again, I said, the cry tells us a lot and helps with all the scoring of the APGAR. Blue extremities, they get a 1. Totally pink, and most of our babies aren't totally pink, they get a 2. And of course, totally blue is a 0. So you add those up, and you can get a total of 10. And I'm correct, my son was a 10. You don't see that very often. Most babies get 8 to 9 APGAR. Muscle tone means the degree of flexion. Acrocyanosis, remember we talked about that? That is a normal finding, and that is for the hands and the feet are blue. That's okay. Just that peripheral circulation is a little sluggish. So we consider a good APGAR to be 8 to 10. Okay? Sometimes they might need a little bit of oxygen blown in their face to get them peaked up. Because again, usually most babies, a lot of babies, don't know where that, are still blue, so they get a little oxygen peak. So typically, what they get marked down on is color. Okay? As long as they're crying and their tone is good, they're doing good. It's just a matter of time before they get that oxygen going through their body. Okay.
What score causes concern?
Less than 8.
Anything less than 8.
Good question. Less than 8, they start doing more vigorous rubbing with the baby, stimulating the baby. They might even not just blow by oxygen, might be bagging the baby, that kind of thing. Less than 8, they need resuscitation. Okay. So the initial newborn assessment or evaluation, respiration should be 30 to 60, and they are irregular, so you do need to count those people. Those are the people who have been through. Know that. We don't want our babies to be retracting, and everybody knows what retractions are, where their chest is, sunken in when they take breaths. You see their ribs, that kind of thing. They're struggling to breathe, and grunting. That means they're trying to get the air out. They go. So those are bad signs. Apical pulse, typically 120 to 160. And again, it's irregular. So you want to listen to it for a full minute. So you want to get respirations for a full minute and apical pulse for a full minute. Temperature, we want them to be at least 97.8 at delivery. Skin color, body pink with bluish extremities. Like we said, we might give them a little blow by oxygen to lift them up. You're going to check the cord, 2 arteries in 1 vein. We consider full term, which you probably got this with the last unit, to be 38 to 42 weeks, right? 40 is exactly full term. We consider full term to be 38 to 42 weeks. And we consider those babies able to stay with their parents for extended periods of time. Sole creases, we look at the soles of the feet, and they should involve most of the foot and especially the heel. So our babies, when we look at our babies, you're going to see a little bit of vernix. Everybody know what vernix is? Yeah. That's that white, it looks like chirping oil. But there shouldn't be a lot at that baby's full term. It should just be in the creases, upper back, the groin area. Lanugo, everybody knows what lanugo is? That baby hair. Okay. There shouldn't be much of that. So those are all things we're going to see more of in a preterm baby. So if a baby comes out and they're covered in vernix and lots of lanugo, that baby's early. Okay, that's a sign of prematurity. We're going to talk more about our preemies in a little bit. Ears should, be curved, and you should be able to bend that ear down and it flip right back. There's not a lot of cartilage in the ear, but it should flip right back, swing right back. We check our males to make sure their testes are descended, and one's a little higher than the other, but you want to make sure you palpate those. Females, their labia majora will look a little bit red and swollen, and that's normal for mom's hormone. And the clitoris, you shouldn't be able to see. So in our preemies, their labia majora is open more, and you can see the labia minora and the clitoris. So it should be nearly covered. Okay. So any babies with an FR less than 8 at 1 minute should not stay with their moms, should be stabilized, and less than 9 at 5 minutes. Respirations less than 30 or above 60 with retractions or grunting are going to head to the nursery with the nursery personnel. Apical pulse below 120 or above 160. Skin temperature, you'll have to warm them up if they're not that warm, 97.8. pale blue or circummoral pallor. Okay. Remember we talked about circummoral cyanosis being a normal finding in our newborns? If they're really pale around the mouth, that's a bad sign. Less than 38 weeks and greater than 42 weeks. You'd think a baby that's post-term wouldn't have problems, but they actually can have some big problems if they're coaching and stuff. Any baby that's less than 38 weeks or greater than 42 weeks would go to nursery typically. Very small or very large baby, and we'll talk more about why those babies need closer attention. And then if babies are born with any congenital anomalies. So one is the fatal or meningomyelocele. Okay, anybody know what that is?
That when everything
Right, sign of infant. Yeah. So, and I've seen that once, where and there's pictures of the television slide up there. Yeah, it's where part of the spine did not close appropriately before birth. It's also called neural tube defect. And what do we encourage moms to take for that? Folic acid. Very important. Okay. So after that initial evaluation or assessment, babies go through transition. Okay. So during this time, you will see that their apical pulse, if you monitored it, would be up to it can go up to 160 to 180. Respirations can go up a little bit too. So they can be as high as 60 to 80. You're going to hear maybe some crackles with birth. You know, the baby, if the baby's born vaginally, it gets put all that extra fluid gets pushed out. But you see this more with our C-section babies. They seem a little wet, so you might hear a few crackles. But then with crying and breathing, they get rid of those pretty quickly. You're going to see apnea, and not to worry. That's why we count their respirations for a full minute. We want it to be less than 15 seconds then. Okay, if it's more than 15 seconds, we're concerned about it. Temperature will decrease a little bit. Infant is alert, startles, and then sleeps for 60 to 100 minutes. Okay, so this period lasts about 30 minutes, and this is the best time for moms to establish breastfeeding. I like to throw that in there, because that baby's awake, and if mom's, and it's a lot of studies have found that if mom establishes breastfeeding, then they have better success. So hopefully, that baby's doing good enough to stay with mom and get on the breast before they go into the sleep phase. And a lot of times, meconium, their first stool is passed down. So there's two periods of reactivity. We call this a period of reactivity. Okay. The first one, like I said, lasts about 30 minutes after birth. Then they go into the sleep phase. And so like 4 to 6 hours later, they might sleep for like 4 hours, 4 to 6 hours. And they get into the second period of reactivity. Okay, another good time to try breastfeeding. And it can last like from 10 minutes to several hours. So if you happen to get vitals during this time, you have to realize that this is probably what's going on.
So the second period of reactivity is basically the transition again, or?
Yeah, they call it the period of reactivity. Yeah. Basically, the first one's more the transition, and the second one's another period of reactivity. The transition is also considered, where they're having a period of reactivity, but they're transitioning
Like, what's happening during the reactivity?
It just occurs where some babies get rushed to the nursery because the respirations are high. They call that transpnea because they're not sure if this is what's going on. It's just their transition. During this transition time, they do it, and then for some reason, they do it again in about 4 to 6 hours, and then that's it.
So they'll go where their pulse will go back up and back down again, or
right,
I'm just trying to figure out like what's happening with the baby during that time frame.
Right. Now
So.
the first one is the transition, definitely, and they're reactive, and their heart rate's higher, they're breathing faster. This is just what they found. It's nothing to worry about. It's just what they see happening with these babies.
So that period right there, the newborn transition lasts the first 30 minutes
30
after
minutes.
birth.
Mm-hmm.
Then you have a period of sleep.
Right.
Then you have another period, which
Right.
you're referencing as a period of reactivity.
Right. Yes. It is just like this. Yes. Yes.
484. Thank you.
If a baby's born and has to go into the NICU because they're not breathing or whatever, does that happen later or does it not happen at all?
It still happens, but you're going to see it not clear up. Okay? So if they're, I know it's hard to know is this baby in distress or not, but if they're not having retractions and they're not struggling to breathe, those are the things that tell us that this baby needs to go to the NICU. Okay? If their pulse is just high and they're breathing fast but no distress, this is what they're going through. Does that make sense? Now, during those sleeping periods, again, you're going to see the heart rate drop down to 100 to 120. The respirations are going to drop down more. They might be a little less than 30. But are they in distress? That is the key. What is their color? Are they struggling to breathe? Okay. Does that help? Yeah. Okay. Okay. So, at delivery, did anybody notice the gasp? I know Ms. Ford talks about that. Did she talk about that gasp that happens at delivery? Did anybody notice that? Yeah. So it's really cool to witness that. So they have a lot going on when they're first born. They take that first gasp, and then there's a lot of changes that happen. Okay. Respirations may be shallow at first, but the signs of distress are nasal flaring, you mentioned that, retractions, running, respiratory rate less than 30 or greater than 60, like I said, at rest, if they're not crying. And you always have to look at that. Is this baby crying? That can make their respirations and their heart rate, like when we screaming out in the throat, our heart rates are going up and our respirations are going up. So if they're at rest and this is what you find, then we're concerned. Okay. Surfactant is what keeps the lungs from sticking together, right? This is produced at 28 weeks gestation. So any of our babies that are less than 28 weeks will probably get some surfactant put in their lungs at delivery. So at delivery, the chest is compressed. During labor, squeezing a small amount of fluid, as we said, coming down the birth canal. And there's a little bit of fluid left, like 80 to 100 milliliters. When the chest is born, it recoils, creating negative pressure, and a small amount of inspiration occurs. So the initial breathing or gasp is triggered by the pressure changes, chilling, noise, light, and other sensations. And it causes that alveoli to open up. Okay. The second reflex cry creates positive pressure space. I know this is a lot to take in. I won't have you recite this in front of us. this distributes a small amount of air throughout the alveoli. Okay. So what fluid is in the lungs will be shifted into the tissues. Okay. Over time. Oxygen, just to tell you what's going on. Oxygen pressure falls, CO2 pressure rises, and the pH falls. And this is temporary because this is hypoxia. It's a temporary period of hypoxia. So it's important part because it stimulates the brain to jolt the heart into sending O2 to the lungs, creating pulmonary circulation. So it's a lot going on. That detail. No. I won't. So the best thing we can do to assist with this big transition to extrauterine life is to suction out the mouth so they don't breathe in any of those secretions. So that's why we have that whole syringe and we're suctioning out the mouth really good and the nose if we need it. Make sure we get all that fluid out. Get their mouth. When the lungs expand, it also triggers the surfactant to be released. And again, that lowers the surface tension, keeping the alveoli open so they don't stick together. Okay.
How much fluid did you say was typical extra?
Like 80 to 100 milliliters, which sounds like a lot. So that's why you might hear, if you listen to the lungs, you might hear some crackles. Okay. So this goes into it a little with a graph here, what all happens. And again, I'm going to graph this out, but just so you kind of know what's going on. It's a big transition. So the first breath reduces pulmonary vascular resistance. Now remember, with fetal circulation, the lungs aren't getting a lot of blood, right? We know all our ducts that transfer the blood away from, like the ductus venosus bypasses the lung, right? And then blood goes into the atrium, just to refresh your memory, and then through the foramen ovale into the left ventricle, and into the aorta, and then most of it goes through the ductus arteriosus, but some of it goes to the lungs, right? We want a little bit of circulation, a little bit of blood to go to the lungs, but just a little bit, okay, because they're not breathing. And then the blood returns through to the placenta through the two arteries. So what happens is, so the first breath reduces pulmonary vascular resistance to the pulmonary blood flow. This dilates the pulmonary vessels, so there is less resistance, and this increases perfusion to the rest of the body. Okay. This causes the ductus arteriosus to close, so there's no more left to right shunning. And then the pulmonary resistance is less than the systematic, so there's more blood going through the lung. So, the foramen ovale closes in about 1 to 2 hours. The ductus arteriosus closes in about 15 hours. And the umbilical arteries, vein, and ductus venosus close immediately. Okay? So that's why you may hear some murmurs when you listen to the baby's heart, because it does take a few hours for those ducts to close, openings to close. Okay?
Ms. Chandler, this is in chapter 23, and you didn't put that in our reading, but you still want to know this chapter.
What part of that?
Well, it says, it talks about
The first breath, or is it just talking about?
well, it's like the blood flow, and then it says how the apical pulse should be obtained for a minute.
Okay, I'm sorry. I'll look at that.
Is that the same? I don't know about that. Is it the same as that? No. I mean, the chart on the
Yeah, this is.
Because I know you want to read. So I'll look at that. Sorry. Okay.
It may just be the blood flow too. I'm not 100%.
Yeah.
But
It may be. It may be what Ms. Ward already covered. Did she cover that?
yeah, she did.
If it's fetal circulation, she covered that.
Yeah.
And this is more, and I've just reviewed that.
Okay.
Basically, you're not going to be tested on that again. But just to know what happens, just what I'm telling you now about
Okay.
it,
Okay.
when it, when they close, a few hours, that kind of thing.
Okay.
All right, and then, blood ends up going to the lungs afterwards, all that good stuff. Okay. All right, heart rate decreases to 80 to 100 while they're asleep, to 120 and 160 while they're awake. So they are in that deep sleep period, and we catch them, which is great to listen to their heart rates because it's easier because they're not crying. We may get it low, and that might concern us, and it would probably concern me too. So we'd have to have the nurses check that out. But it can occur if they're in deep sleep. So we may wake them up and see if their heart rate goes up. Okay. We don't typically get blood pressures on babies unless they're having problems. So the babies in the NICU will have their blood pressures checked, but just our normal newborns, we don't do blood pressures. Okay. But if you were to do a blood pressure, it would be 60 to 80 systolic and 40 to 50 diastolic. Sometimes you can even see on the babies the point of maximum impulse. So you can see their little hearts beating through their chest. And, apical pulses are how we get all babies' pulses, right? You guys know that. We listen for a full minute. More than half of all murmurs heard in the neonatal period disappear by 6 months. So if we do hear a murmur, we definitely let the nurses know, or we check to see if they're aware of that. And they will watch that, do some studies on it also to make sure it's not something major. But most of them, it's reassuring to know that they disappear in 6 months. Okay. Looking at their lab work, which they usually don't even do on newborns unless they're sick. But if they would do them, this is where they find that the hemoglobin and hematocrit are a little bit high. Look at that white count. 10 to 30,000 is normal. So they don't handle infection well. Our newborns don't. The white count's already elevated. So what we will see in our newborns that are septic or have infections is a low white count, not a high white count. Platelets and are a little high also, but the clotting factors are not present. And what do we give babies to help them with that? Vitamin K, exactly. And the reason they don't have the factors is it's made in the colon, the bowels, okay, with bacteria. So they don't have any bacteria in their bowels at delivery. So we have to give them vitamin K so they don't have bleeding problems until they synthesize vitamin K themselves. Glucose, if you look at the glucose, we would think this was pretty low on an adult, okay? Typically 45 to 96 on our newborns. We like it to be 40 to 45, so the lowest number we would want is 40 on our newborns. And we'll talk more about who we monitor, which babies we monitor more closely, monitor the blood sugars more closely. Yes? No, just in general, that their white count is high and that their white count would be low with an infection. Okay. And again, they don't have the clotting factors, that's why we give the WK. Okay? And the blood sugar, the blood sugar, that we don't want it less than 3. All right, so we kind of hit on this already, but there is rapid heat loss, and that's a real concern with our newborns. They do not have a shivering mechanism established yet. And of course, establishing respirations is the most critical for our babies to do. But next should be heat regulation. And of course, thermoregulation is the balance between heat loss and heat production. Remember about brown fat? It's unique to the newborn and it regulates thermogenesis. It helps keep those babies warm.
What did you say after establishing respiration?
It's next. Okay, establishing respirations is the most critical, and then the second is thermoregulation.
Heat loss versus heat production.
Because thermoregulation can cause a lot of, if they're cold, we'll talk about cold stress. So the less mature a baby is, the less brown fat they have. And so we're even more concerned with our smaller, premature babies getting cold because they don't have that additional brown fat. Okay. We hit on this a little bit yesterday on that one slide, but how do babies lose weight? Weight. Okay, so convection is flow of heat from the body to a cooler current temperature. So if there's a breeze in the nursery or in the delivery room and they're not wrapped up, then they can lose heat. Radiation is loss of heat from the surface to a cooler surface, from the body surface to a cooler surface, but not in direct contact with it. So like cribs and examining tables need to be placed away from outside windows because they'll be cooler on the sides and the baby's heat will go to those cooler surfaces, radiate to them. Evaporation's an easy one, right? We want to dry those babies off really well right after delivery because the drying, the liquid is converted to a vapor. There's a cooling effect. Loss of heat. And conduction is when they're actually in contact with a cold surface. So that's why we always heat up those radiant warmers. If we're going to put the newborn on that radiant warmer after delivery, we want it to be warm, right? So that's loss of heat from the body surface to a cooler surface. You want me to run through those one more time? Okay. Convection is flow of heat from the body to cooler current air. So you want to make sure the babies, moms like those rooms really cold because they've got all these hormones going on and they're having hot flashes and the diarrhea. So they're more comfortable with it a little cooler. So we as the nurses have to monitor that and make sure it's not too cool. Radiation is loss of heat from body to a cooler solid surface, but not in direct contact with that surface. So that's where we keep them away from those drafts, cold windows. so the cribs are not cold. Evaporation is easy one. Lots of heat. When liquid is converted to a vapor, we need to dry our babies off really good. And conduction is when they actually have contact with a cold surface. They will heat. You need to be aware of all those. Okay. So babies do have less cush than we do. They have less thermal insulation. So that's why they keep themselves flexed. Okay. Our preemies don't tend to have as good a tone, so they're more floppy. So again, we worry about our preemies getting cold a lot more so than our newborns. So their flexion keeps them warm. We all like to curl up in bed, fetal position, get warm. That's why it keeps you warm when you're in a flex position. They also have a large body surface to weight ratio, which makes them lose their warmth quicker. So our concerns are if our baby gets cold, they will get stressed. And if they get too warm, they will be stressed. Some moms bundle them up, crank up the heat, they go the other direction. They're so afraid their baby's going to get too cold. And that's not a good thing either. But cold stress leads to increased oxygen consumption. Okay, because they're trying to warm themselves up, which leads to increased respiratory rate, which leads to pulmonary vasoconstriction, which leads to decreased O2 uptake by the lungs. So the cold leads to increase in oxygen consumption. So they increase their respirations. And the increased respirations lead to pulmonary vasoconstriction, which leads to decreased O2 uptake by the lungs. And it also causes, this increase in respiratory rate also causes peripheral vascular constriction, which is decreased oxygen to the tissues. So all this is really not a good thing, right?
Will you repeat that?
Yeah. First or the second part?
The second part.
Okay. So the increased respiration leads to pulmonary vasoconstriction. We got all that. Okay. Increased respiratory rate also leads to peripheral vasoconstriction, which leads to decreased O2 to the tissues, which leads to increased anaerobic glycolysis, using up more glucose, and a decrease in PO2 and pH, finally, metabolic acidosis. I gotta know your reword, because that's confusing, isn't it?
Decreased pH and CO2.
No, not CO2, just it causes more oxygen consumption, okay? And so they're going to increase their respiratory rate. And let's simplify this. So also leads to decreased tissue perfusion, okay? And they end up using glucose to try to warm up also. So what happens if they're using more glucose? Hypoglycemia. Okay. So it's kind of like a domino effect. If they get cold, they're trying to warm themselves up, and they end up getting into big problems. Okay, let's look at the diagnosis. The fetal liver stores iron in the utero. At birth, the infant has iron stores sufficient for 4 to 6 months.
I'm sorry, what about 4 to 6 months? Sorry.
The fetal liver stores iron in utero. Okay. At birth, the infant has iron stores sufficient for 4 to 6 months.
Okay.
Okay. So glucose is used for energy. I think we can all agree. And when those stores are depleted, metabolism changes over to fat metabolism from carbohydrate metabolism. So, and we all know that from diabetes, right? That energy can be derived from fat and protein as well as carbohydrates. A little bit about bilirubin. Bilirubin is a result of phagocytosis. Everybody knows what phagocytosis is? Eating up of the, gobbling up of the RBCs. And this is what we see a lot of times in our babies. So they get an additional rush of blood from mom at delivery sometimes. And so that can cause them a bigger problem because they have to break down more of these RBCs. And then they get jaundice. So there's 2 forms of bilirubin. There's the unconjugated form. And this is the changing of bilirubin into excretable form. So conjugated is changing of bilirubin into the excretable form. And unconjugated or indirect into the water-soluble pigment form, excretable.
Mm-hmm. Unconjugated is what? I'm sorry, I can't write fast enough.
Okay. Unconjugated form is indirect bilirubin. And I'm sorry, I should reword this. Okay. Conjugated can be excreted. Unconjugated is not excretable. Okay?
You said water soluble?
Right, the conjugated. So it can be excreted and unconjugated cannot.
But you had said another place that the unconjugated goes, and I didn't catch that.
Yeah. Conjugated or changing bilirubin into excretable form is the conversion of the yellow lipid-soluble pigment, unconjugated, indirect, into water-soluble pigment, excretable, direct.
Wait.
It's confusing. Just remember, conjugated is conjugated is the excretable form, and unconjugated is not. It is transferred to the liver, unconjugated. Okay, it is attached to an acid, and it is excreted through the bile and the duodenum.
That's where it was again.
In urine. Sometimes the billy can be deconjugated. It will be reabsorbed into the intestines and back into the liver. So this unbound bilirubin permeates into the extravascular tissues, resulting in jaundice. Total bilirubin is the sum of the conjugated direct and the unconjugated indirect bilirubin. So we look at the total bilirubin. Don't worry too much about that. Let's just move on to the jaundice. Okay.
So we just basically, for the test purposes, need to know that they store the iron in utero and they can make it about 4 to 6 months.
Yeah. Something that's
Okay.
yeah. Yeah. I'll try to read that a little further. I'm sorry. All right, jaundice. So let's just talk about that. All right. The physiological jaundice, and they call another type of jaundice breast milk jaundice. So physiological jaundice occurs because the newborn has a higher rate of bilirubin production and reabsorption of bilirubin from the neonatal small intestine. Okay. So they just have higher bilirubin because they're breaking down more red blood cells. Serum levels will be approximately 4 to 6 milligrams per deciliter when you start to see yellowing of the skin. 4 to 6 milligrams. And this occurs in about 50% of all our full-term babies and 80% of our preterm babies. So the liver is more immature in our preterm babies, is why they have a harder time with jaundice. Normal physiological jaundice occurs after the first 24 hours, postnatally. So after birth, 24 hours after birth. And if it occurs before that, it's more serious. I'll talk about that in a second. Okay, and generally what you're going to see is it starts in the head and works its way down through the body. So you're going to see the face first. We're going to notice a little, if you tap on the nose and you can lift up your finger, you're going to see this yellow tint. You're also going to see it in the sclera of their eyes and their mucous membranes. And then it moves down. It peaks about 3 to 5 days, and that's why many times that we send the babies home, they come back to the office again for a weight check, make sure everything's going well, with feedings, and to check their color, their bilirubin check. And it peaks 3 to 5 days in a full-term infant and 5 to 7 days in the preterm infant. So when we say peaks, what happens when it peaks? It starts to come down. So we want it to start to come down at least by 5 days in our full-term babies, and at least by 7 days in our preterm babies. So kernicterus is the most serious complication of neonatal hyperbilirubinemia. Okay? That's where it gets into the brain. So we want to make sure that we lower these bilirubins quickly. So what do we do? How do we do that? Phototherapy, right? Put them under the billy lights. Also feeding them a lot, so it will push it through the urine, the stool, and then you'll start to see it in the stool, and you'll start to see it in the urine. The urine will be a little brown. So breastfeeding, yes. Phototherapy, bilirubin lights, yeah. And did anybody get to see the transcutaneous bilirubin scanner that they do on the forehead?
We did.
On the butt? Oh, wow. Really? Oh, they drew blood. Okay, yeah. So nobody got to see the
We
little
did. We did have a review the first week.
Oh,
She
good.
took her to the nursery and did
Good,
the.
good. Yeah. So that's a great screening. So we don't have to prick all the baby's feet to get their bilirubins checked. And I should remember this, what the level is. I believe if it's greater than 10, but it depends how old they are. So they put it all on a graph, and it's become much more scientific. It used to be when I worked in the nursery, it was like 12. 12 was the magic number, but it just depends now on how old they are. Are they preemies? Are they full-term babies? That kind of stuff. But 12 still kind of seems to be the point where we're going to start treating, putting them under the blue lights. Is that what you find? Yeah. Okay. So what they've linked breast milk jaundice to is it's linked with poor feedings. Okay, so it's a little bit of dehydration going on with the babies. We don't want to discourage our moms, but it does happen. And they're not getting as much fluids, which, you know, shouldn't be a concern because it's baby, but the colostrum, definitely, there's not as much colostrum that the baby's getting as opposed to formula. Some docs will want these moms to give them formula after they breastfeed. They're kind of getting better about not doing that as quickly. So what we want to do is encourage our moms to just breastfeed every 2 hours if they kick them down. And it's going to get better once their true milk comes in. You know, the colostrum is awesome. It's got all these antibodies, but there's not a lot of it. So they naturally get a little dehydrated, and that adds to the problem. Usually, it like I said, it appears by 24 hours and disappears by the end of the 7th day. So a lot of times what we tell our moms is go home, you know, if it's not that high, but it's kind of high, put them in front of a sunny window. Because the sun also helps them break down that bilirubin and get rid of it when they're in their stool. In our preterm babies, it's first evident in about 48 hours and disappears by the 9th or 10th day. So typically, again, serum concentrations of the unconjugated bilirubin doesn't exceed 12 typically in our term babies, and typically doesn't exceed 15 in our preterm babies. So if it's higher than 12 or higher than 15, if it's higher than 12 in our newborns or full-term babies, they'll get treated, and if it's higher than 15 in our preterm babies, they'll get treated. And again, there's more science to it than there used to be. How quickly it's gone up. Okay. Also, it should not go up any higher than 5 milligrams per deciliter per day. So a little more about kernicterus is it can cause cerebral palsy, epilepsy, mental retardation, if the infant survives. So that's why we put them under the belly light and get that level down. Oh, you guys are ready for break. You want me to finish management real quick?
Yeah.
Okay. All right. I know. Sorry. Okay. All right. Here we go. All right. Was there a question back there? No? Okay. All right. Real quick. So the big thing is, baby gets naked under this light, okay, and we put a mask over their eyes to protect their eyes, and basically they sit under this light. Now, some doctors will let these babies be at home with a belt, which is really cool, because then you can still keep that baby wrapped up. But if we do this in the hospital, we do the lights. So they have a fluorescent light shining on the baby. Sometimes we have double lights. We're really concerned, so there'll be one at the top and one on the side. The big thing is, since they're only in a diaper, you know, because we want to get as much skin exposed to that light, we need to maintain their temperature. And usually the light itself keeps them really warm, so we want to make sure they don't get too warm. So how we do that, and usually they leave them in mom's room if mom can stand the light. The light's kind of overbearing, but they usually stay in mom's room, We bring the lights in, they're in their little bassinet, and we just encourage moms, the more they can be under that light, the better, because it'll break that bilirubin down quicker, and they can get out more fast. So we encourage moms to feed them frequently, but as soon as we feed them, it's not cuddle time, it's put them back under the light. So we want to make sure we're checking their temperatures, that it's not too high and not too low. We don't want cold stress, and we don't want hypothermia. We're going to monitor the stools because we'll see the stools themselves become darker with the bilirubin, so that'll be a good sign. Frequent feedings, early and then every 2 to 3 hours. And we try to turn them like every 2 hours, so on their back, and then the next time on their stomach. And like I said, they have the eye patch. Some babies don't like to be under there very much because, you know, they like to be swaddled, they like to be loved and cuddled, but so it's hard on moms. So it's our job to, you know, just reassure them that it's gonna be okay, that that's the best treatment is to keep them under those lights as much as possible. Okay. So how about coming back at okay. How about a 15-minute break? Okay. Is that good? Okay.